for me, there's several goals. One is to look at, do we see any additional benefit from combining these strategies together? So the data that I showed prior was looking at these individual targeting strategies, but it might be a bit more beneficial to actually target from both sides. And the example I'll give, we kind of have some ideas from, the GPANTs, the triptans, and opioid systems. And so these are all drugs that are very effective for different types of pain. Like I said, triptans and GPANTs are really headache selective. But what makes them so interesting is that they have multiple sites of action, and those sites of action tend to be either on both sides of the synapse. So for opioids, opioid receptors are expressed both pre and post-synaptically and at many different areas throughout the brain. CGRP receptors are expressed in blood vessels as well as neurons. And so by targeting those receptors, you're having two different sites of actions that typically work in concert. Likewise, for the triptans, they have receptors on the blood vessels as well as the neurons. And so what we find is that with these degradative enzymes, they're expressed on blood vessels, presynaptically and postsynaptically, right? So now we have an idea that maybe we can target not just two, but three different sites of action. And they're also highly expressed at various areas throughout the brain. And so that's the first arm is, can we do this quote unquote polypharmacy with these agents? The second is, when moving and thinking about moving things into a clinical setting from the preclinical standpoint, you really want to look at the side effects and the side effect profiles, right? And so targeting the cannabinoid system, typically, when you think about this, people think of either cannabis or THC or CBD, but that's a different story. That's a different arm of the story. And, there's concern over reward liability, right? Are people going to want to abuse the agent, or are we going to have a sedative side effect, right? Where maybe the pain is gone, but the quality of life is still diminished because people aren't motivated, they're sleepy type things. And so really trying to investigate whether or not this is a strategy that's void of those side effects. Likewise, when we talk about opioids, which really aren't indicated for headache, but they, are still used in some settings, are there other side effects? And so, in particular, we're interested in breathing. And so a different component of my lab has shown that the endocannabinoid system maintains respiratory drive. And so we want to make sure that any manipulations that we do are not going to be detrimental to a critical piece of life. You're not breathing, you're not alive, right? But really, and then really trying to understand mechanistically how is 2-EG working through these cannabinoid receptors or other to advance the science, right? So there's I want to move things into a clinical setting and that translational component, but there's also the science side and really trying to understand, this is a system, this endocannabinoid system is one of the highest density systems throughout the nervous system, if not the highest from the receptor level. And it plays a role in motivation, in feeding behaviors, in reproductive behaviors, all of these different things. And so, really, even though those things are known, like it plays a role in all of these different components, we really don't know very much about it and how it's regulated. And so that's the next step as well, is trying to understand, are hormones playing a role? Are these other systems that were talked about throughout the conference playing a role? Does sleep play a role in circadian patterns and over lifespan, right? So there was talks about pediatric headache versus adult headache. And we know from our previous works that there's definitely changes in the endocannabinoid circulating levels that they change over lifespan, they change at puberty, they change at menopause. And so really trying to understand relative to the human condition of migraine, where from the sex standpoint and sexual dichotomy, prior to puberty, boys and girls have a very similar risk and presentation of headache. It really splits into that female dominant functional pain syndrome at puberty. And then at menopause, or the male equivalent, it comes back down to about 1-to-1. And so really trying to understand what's going on in that standpoint.